All right. We are streaming to Facebook. Let me just go confirm. There we are. All right, we got a few people waiting in the room already, so let's not keep them waiting any longer. Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and Neuroendocrine Cancer Foundation program brought to you by several sponsors, which we'll indicate in a second. And the Neuroendocrine Cancer Foundation, if you don't remember, is the new brand name of what was previously and historically known as LACNETS. Same people, same organization, same programming. Stay tuned for all the things that we're working on together. One of the main things that we have been doing in this collaboration between the two foundations is the support line, which you can find at ncf.net/support line. We'll also try to include that and other links to anything that's referred to today, resources, etc., in the comments section. If you don't know me, my name is Rain Bennett. I am your host this episode and every episode. I am a filmmaker and a writer, and I've been working with CCF and NCF now for several years to create all kinds of video content. So a live video series, kind of webinar question, Q&A session like you'll see today, but we do patient-centric documentaries, treatment-based videos, all kinds of videos, but with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. Now, if you are new to this community or new to this show, I want to say welcome. I'm glad you're here. And I highly encourage you to reach out. You can see some of the people in the comments section saying hello and where they're signing on from. I do that intentionally. I ask for that because, one, I like to see how far the program reaches. We have people from all different countries tuning in live every week, which is incredible to see, but also so that you can see people in your community, people you may know. This community is so incredibly strong. The patients, the caregivers, the support group leaders, the specialists, everybody is fighting for one another, and it's really a beautiful thing to see the strength of this community. So my point is, if you embrace the community, they will embrace you back. A lot of the value from this show is the shared experiences and shared stories from within the community, not just the information you'll get from our guest today. Before we get started, a little bit of an announcement. I know that CCF, Carcinoid Cancer Foundation, who initially started this show, posted a post recently that I've been getting some questions about, and the foundation has been getting some questions about recently. I forget exactly what they said on the Facebook post, but the show, Luncheon with the Experts, is going nowhere. We are already booked for almost the rest of this year. That was one question that I was getting from people who are really big fans of the show, so no need to worry about that. NCF has been conducting that this year. And as far as CCF, and I have worked with CCF for over 10 years, but I am not necessarily an employee of the organization. But it is just an assessment period to step back and look at how they can best contribute to the community. This is a program that's had many pivots, for lack of a better expression, over the 50 plus years they've been in existence. And so they are just taking a moment to step back and look at how they can best serve you all, the community. In the meantime, the show still goes on. NCF is still doing all of its programming. So really, you all shouldn't tell a difference. Hope that helps alleviate some of your concerns. Before we get started, we also want to say thank you to our presenting sponsors, which I have this little boom. Look, we could do it just with a graphic. Without their support, we couldn't do the show. So let's get to the show. I am excited to welcome back to the show Dr. Julie Hallet. How are you, Dr. Hallet?
I'm really good. Thanks for having me back. It's always lovely to participate in this program.
Yes, I appreciate you. You've been here a couple times. It's been a little while, I think. To be honest with you, the years fly by so fast these days that I tend to lose count. But for those who may not be familiar with you and your work, tell us what you do, where you work, and the role that you fill in this community I was alluding to.
Yeah, so I'm a surgical oncologist. I do cancer surgery, focusing mostly on the intestine, pancreas, and liver, with a subspecialty in neuroendocrine tumors. And I practice in Toronto, which is the largest city in Canada, located in Ontario. We have a multidisciplinary specialized neuroendocrine clinic called the Susan Leslie Clinic for Neuroendocrine Tumors at Sunnybrook. And so I work there with a team of medical oncologists, radiation oncologists, interventional radiologist, endocrinologist, and so on to care for patients with neuroendocrine tumors specifically.
Got you. Well, welcome here. We always have a great showing from folks in Canada, as you can probably see. Folks at home, quick little best practice lesson for you all. It's very hard in this format. I know I say this every week, but it's important. It's very hard in this format to field very case specific questions. So, the best way to get answers to your questions and guidance along this journey is just short little generic chunks. There is no maximum to questions that you can ask. You can always ask follow-up questions. If we do, or Dr. Hallet needs some clarification on something, which sometimes does inform the answer, we'll ask for that. And if you're still in the call, then you can provide that clarification. But super long, super dense paragraphs that are very unique to your situation are hard to read and hard to field in this manner. Just a little caveat to consider. That being said, go ahead and start sending in those questions, and we are going to try our best to get to all of them. We have 54 minutes starting from now. It does move by very quickly, so go ahead and get your questions in sooner rather than later. Often I am playing catch up to get to them all, but that's better than a flood of them coming up in the last 5 minutes. So wink, wink. Dr. Hallet, we were talking beforehand about the collaboration CutNets. Could you explain to me again what that is for the folks listening? I thought that was a pretty cool example of the community we were talking about.
Yeah, absolutely. So we're talking about a community for patients. There's also a huge community of physicians, researchers that work with neuroendocrine tumors. And in my professional career, probably has been one of the most rewarding communities to be a part of. And, we end up talking a lot about research or how to move the field forward, in particular in surgery. Because a lot of what we're going to be talking about, the answers I'm going to give you for surgical management today, is based on studies that look back at patients that have already been treated, what we call retrospective studies. Often they come only from one institution. Often within that institutions, all patients were treated by one surgeon. So, it's not the best data we can have to define how to treat people. It's the best we have for surgical management, but that's very different from what we see in, systemic therapies like somatostatin analogs, PRRT, or chemotherapy, where they have like much better data to inform treatments. So, when we talk between surgeons at those different meetings, we're saying like we need to do better, and we can do better. We just have to get together to do that. And we were starting to have, some little research initiatives with different centers, all sort of individual initiatives. And at some point, we all said, well, let's just all get together, right? Like, why do all these different things separately when we can really group everybody together and have a very intentional plan of what we need to study to make surgical treatments for patients with neuroendocrine tumors better. And so that's how CutNets was created. It's a collaborative of surgical teams that care for neuroendocrine tumors. We have 27 specialized centers for neuroendocrine tumors across 11 countries in North America and Europe. And we just started this year. We're building different research questions, all with the hopes of, improving care and improving outcomes for everybody.
Got it. Thank you so much. Quick question. How important is it for doctors and specialists in your field? We talk often about multidisciplinary teams, et cetera, tumor boards. How important is it for this disease for specialists to have that sort of connection and collaboration and conversation, discussion with each other about this disease?
I think it's absolutely crucial. Like, we often work, like we said, with an uncommon disease. I don't want to say that neuroendocrine tumors are rare anymore, because they're not, but they're not as common as other types of cancers, right? So we all have our own experiences, but sometimes it can feel lonely because there is not many specialists per countries or per region. So we really need to talk with others, bounce off ideas, different perspectives, get challenged so that we don't get too comfortable in what we're doing. And we cannot do that without connection with other of the same specialty. So for me, other surgeons, but also other oncologists, endocrinologists, radiologists, and have that community. I think diversity of opinion and perspectives makes everything better. And part of that is also having input from patients, right? Like, what we do ultimately is all to improve care and outcomes for patients who live with neuroendocrine tumors. And if we don't know what's most important for all of you, we cannot find answers and we cannot find solutions to that. So we need to hear that. And with that in mind, as part of the CutNets collaborative, we build some strong partnerships with patient partners. In Canada, it's the CNETs with the Neuroendocrine Cancer Foundation by their new name. In the US, Neuroendocrine Cancer Australia as well. And we're building new partnerships also with group in Norway and Italy, and probably in other regions of Europe over the years.
Gotcha. Thank you. Special shout out to all the folks from North Carolina, or at least in North Carolina. I know there's a conference in Charlotte this weekend. If you didn't know, that I am based in Durham, North Carolina. So special shout out to all those folks. Not that I don't love the rest of you. Questions are already coming in, so let's go ahead and pivot to those. First one I see is from Shane. Shane says, with NETs being hypervascular, what are your thoughts on blood transfusion after or during surgery? Could this fuel post-surgical growth of the remaining tumors?
That's a really good question. Not specifically for nets, I would say. So I don't think the hypervascular nature of nets really impacts the way transfusion may influence outcomes. But we do know that transfusion have an influence on outcomes after cancer surgery in all types of cancers. So not only neuroendocrine tumors. What I would say about neuroendocrine tumors specifically is because most of them are very slow growing, then the impact of transfusion might actually be less than in other cancers. Because even if something stimulates cancer growth a little bit or increases the risk of recurrence from the cancer, because neuroendocrine tumors are so slow growing, that impact might not be as big in that particular type of disease. But we know, and I've done a lot of research on this, that every time somebody gets a transfusion, it can interact with the immune system. So the immune system is not a lot, but a little bit diminished when you get a transfusion because it comes from somebody else, right? It's the blood that belonged to another person, and it triggers the immune system. And by doing so, we believe that it can increase the risk of infections, for example, after surgery or other events immediately after surgery, and in the long term may have an influence on survival and recurrence. That is not to say that you should never get a blood transfusion. Blood transfusions can be life saving, right? There's instances where you absolutely need it to make it through surgery, and then it's fine. It's a balance of the risks and the benefits, right? There's some small risks, but if it allows you to get through the operation and get rid of the cancer, then it can be a good thing. What my group and others have been doing is trying to avoid the blood transfusions that are avoidable. About 40% of all blood transfusions given around surgery could be avoided. And those are the ones that we want to sort of reduce the rate of with some of the research we're doing. But there's really a 60% that are life saving and should still be given. I hope that answers the question.
Yeah, thanks, Shane. Appreciate you. Next question from Dina. Dina says, can lanreotide shots cause weight gain and itching skin?
Good question. It not directly. I don't think lanreotide is like an exceedingly well tolerated medication. Some people have few side effects immediately after the injection, like cramps or diarrhea that lasts for 2 to 3 days and will eventually resolve. But I bet that most of you know about this better than I do. With regards to weight gain, when I said not directly, it's because sometimes lanreotide can create hyperglycemia, so high blood sugars, and then that needs to be managed that it doesn't lead to weight gain eventually. So I guess it's like an indirect mechanism, but could happen. So it's important that blood sugars be monitored while you're on lanreotide, and then you can engage your family physician or your oncologist with that.
Got it. Thanks, Nina. Next question from Judd, I think. Let me know if I'm pronouncing that correctly. With complex liver mets, are there new or evolving surgical approaches or ablations, complementary therapies, etc., that you are finding success with?
There's lots happening with liver surgery or liver-directed therapy for neuroendocrine tumors. I'd say that the future right now is combining some of those approaches. Our goal is always to treat as many tumors as possible, as you know. So we want to aim for treating at least 70% of the bulk of the liver lesions. And to do that, we may combine approaches like resection, so like scooping out. I tell my patients it's like ice cream scoops, like I scoop out one lesion at a time in the liver. So that's resection. We can also use ablation, like using microwave or radiofrequency techniques. So we essentially put a needle in a tumor and we'll burn it. Can be done during surgery, can be done after surgery in radiology. And then we combine all these things together to get to the maximum amount of tumors that can be controlled in the liver. I know that there's new approaches people might have heard about, like Istiosonics is one company that's pushing a lot of their products right now, irreversible electroporation or IRE. Those are all things that I would say are experimental right now, and we don't really know where they fit in the treatment. So, if anybody is looking at that or discussing that with their care providers, I'd suggest it should all be done on a clinical trial protocol. So, where it's really like experimental and investigation, and it's not standard of care at this time. We really don't know where this is going to go in the future. So, I guess that's what I would say for that now. And with the last thing being that I think it's important to push the role of surgery there. Like we often hear about new treatments, like new medications that are approved by the FDA that add new lines of therapies. But when we go through all those lines of therapies with medications, we often forget at the very beginning, surgery might have been an option, and that surgery at the very beginning may have been able to delay the need for those other therapies so that you have more treatment options for longer during your disease journey. So combining options to control more liver tumors is the future for me. And then making sure that as many patients as possible have access to a surgical assessment by an expert in neuroendocrine tumors and can benefit from surgery early on in the course of their disease, so that we can stretch the options over time.
Got it. Thank you. And thanks for your question. I have a question about from Larry about the CutNets group that we mentioned earlier. Larry says, you mentioned 27 centers for net surgical specialties around the globe. Where can we find a roster of these facilities?
So we don't have a website right now. We're working on one. It's all on a volunteer basis right now. So this is like a little going a little slow. But we did publish the initial identity card of the collaborative, if you wish, and that's available in the British Journal of Surgery. There's also um, um, a tweet that is pinned on my Twitter, or sorry, X, we should say now. It's been a few years. My X profile, and I can post the card that has all the centers on there later today, if you all want to look it up.
Got it. Got it. Thank you. Appreciate it, Larry. And yes, it's still hard to say X.
Yes,
I think people will always call it
yeah,
Twitter.
doesn't seem natural.
And I know. From Jeff over on YouTube, what is new relative to combination therapy for immunotherapy to make PNETs more immuno amenable?
With specifically for immunotherapy. So with combination therapy right now, the medical oncologist would know like the very last trials that are going to open. I'm not aware of all of them, but there is not a lot happening with combination therapy specifically for peanuts. There's some that are going on, in particular with PRRT, and often they will treat more than one disease sites. Um, I know that the people are working on establishing new trials for immunotherapy, but they may not be open or officialized yet. One thing that we found with neuroendocrine tumors in general is that they're not responding very well to immunotherapy. We don't know why, but are kind of immune poor, for a better word. And the trials that we've had about immunotherapy have been quite disappointing. So, your question about whether we can combine therapies is really what people are thinking of right now, trying to see if there's other agents that we can use to increase that, what has been a disappointing response so far.
Got it. Thanks, Jeff. Next question. Can problematic abdominal lymph nodes be removed laparoscopically?
They can, but I would say that it depends what we mean by problematic, and then it depends on the
Okay.
lymph node. So, like lots of things you'll hear me say today is it depends. There's never anything that's completely black or white in surgery, and especially in surgery for a neuroendocrine. So, in general, abdominal lymph nodes that would be problematic are those that are located in the mesentery. So that's the sheet that houses all the blood vessels that go to the small intestine. And the reason they become problematic is because they have fibrosis around them. And even small nodes can create lots of fibrosis. What the fibrosis does is sort of tethers everything around it. Think about your blood vessels going to the intestine, and the intestine loop can be like trapped in a spider web, sort of. And over time, that can reduce the blood flow to the intestine or create blockages on the intestine, which creates pain and all sorts of other problems. So when we see nodes that are larger and are at risk of developing this fibrosis and those problems in the future, yes, we can go in to remove them to prevent those problems. That can sometimes be done laparoscopically, with the caveat that they might be difficult to find with laparoscopy, and they might be difficult to resect in such a way that we can save the intestine. Every time we go for nodes like that, they're located on the blood vessels, right? So if we remove them with the blood vessels underlying them, we have to remove a chunk of intestine. And with neuroendocrine tumors, we want to avoid that as much as we can. We want to keep as much intestine for you as we can, because you'll need it if you develop diarrhea for carcinoid syndrome or recurrence in the future. So often when we resect those nodes, that we want to do is we want to peel them off the underlying blood vessels if we can, and spare as many little branches as possible. And that is very hard to do with laparoscopy. So all that to say, it depends. Number one, it has to be a node that is or could become problematic. And then number two, open versus a laparoscopic surgery depends on the ability to remove it without sacrificing a lot of little blood vessel and intestine.
Got it. Thank you. Back to the subject of transfusions, which we spoke about earlier. Larry says, I formally provide regular donations to blood banks. Since my relationship with NETS, I have been unable to get an answer regarding continuing this practice. Okay, I see. Would I be a viable blood donor, or am I putting a potential recipient at risk?
With NETs specifically, that's hard to know. What I would suggest is ask the blood banks. They have very specific protocols for that, which is to protect both the donors and the recipients. And things tend to change over time. So I'm not sure where things stand right now with regards to people that have indolent cancers like neuroendocrine tumors. But I think most blood banks would be able to give that information. I'm sorry if you haven't been able to get it thus far.
Next question from Eileen, which may be a little case specific, but we can still talk about the issues. Eileen says, would you advise surgery for a sub-centimeter non-functional PNET on the tail, less than Ki-67 less than 3%, or watch and wait?
Yes, I would say that in general, small non-functional pancreas neuroendocrine tumors, so that means tumors that are less than 2 centimeter and have all good features. So the good features are what we see on imaging. So, making sure that it is less than 2 centimeter, there's no enlarged lymph nodes seen on imaging, the pancreatic duct is not dilated. If all those characteristics are met, then it is safe to watch and wait. Actually, I would say that doing surgery presents a higher risk for someone's life than observing. So, there's a saying in medicine, in Latin, it says primum non nocere, so first do not harm. We don't want our treatments to be worse than the disease itself. So when there's small, non-functional pancreas neuroendocrine tumors that have all good looking features, they can very, very safely be monitored. And we know from studies across different institutions that when people are observed, nobody has progressed towards having a spread outside the pancreas or having a tumor that grows to the point of not being amenable to surgery. So in the very, very, very small group of people where the tumor may grow and require surgery, that can be caught within the first year and a half, and people don't miss a window for surgery. And that's really the minority. So all that to say, it is safe if all the right features are in there, and that actually is consistent with recommendations from most international organizations.
Got it. Thank you. Folks, just a quick little tip. If you want to add the captions to read along, this is pertaining to a next question that is in Spanish. There is a little button on the bottom of your Facebook. I'm not sure about YouTube, but no, I think it's there on YouTube too. That says CC, and you can hit that bottom at the button at the bottom right, and that will bring up the text as we're speaking. And I'm hoping this is for Adriana. I'm hoping that when we answer this next question in English, it will translate it in her native language. So, Adriana from Uruguay, we don't have any NET specialist here. I was diagnosed with carcinoid syndrome 6 years ago. After all the tests, PET, MRI, bone scans, et cetera, they still haven't been able to locate it. I'm taking Sandostatin LAR, 30 milligrams every 21 days, but my symptoms are worsening. So the question is, and it's a broad one, but like, what advice do you have for Adriana at this point? There's no NET specialist, and she has symptoms. Apparently, she was diagnosed with carcinoid syndrome, but they aren't able to locate the tumor.
So first off, I'm sorry you're going through these challenges. Sadly, it happens to a lot of people with neuroendocrine tumors and carcinoid syndrome. There is a very small number of people where we will not find a primary tumor, and then I think treating with somatostatin analog is a good thing to do. If you want to look into this more deeply, I don't know what's feasible in Latin America, if it's feasible to go to another country for an assessment at least, but there are some great neuroendocrine specialists in Mexico and in Panama and Colombia that could potentially help, but that really depends on what's available locally.
Oh. Okay, thank you, Adriana. Let me know if you have any other questions. Next question from Eltaz. Eltaz says, I had 4 rounds of PRRT. After 6 months, blood test flags decline in hemoglobin. What could be the cause of that?
Yeah, sometimes PRRT can have an impact on the bone marrow. And so that can impact the production of different cell lines in the blood. So what I would suggest is check in with your oncologist, and you should be able to do the right test to see if it's related to that. There could also be a lot of other cause for a drop in hemoglobin. Could be related to primary tumor itself, could be related to prior treatments if you had any. And then sometimes it could also not be related to neuroendocrine tumor. Something that we often forget with neuroendocrine tumors, people will live for a very long time with the disease and be treated, and you're perfectly allowed to have other problems. So it's important to also consider those and chat with your family physician and your oncologist.
Yeah, I think that's a great general point to make too. I mean, if you're dealing with this, if anything goes wrong, I assume your mind could just go to that, but it doesn't mean, would you say you're allowed to have other problems?
Yeah, and it's not only like your mind as patients or care partners, it's also the physician's mind, right? I'm sorry. I have many patients who go to the emergency department, and then it's like they have a label of neuroendocrine tumor, right? Which is a good thing. Like, people need to know you have this disease, an uncommon disease, and it has to be in their mind. If it's not on the chart, they will not think about it. So it's a good thing. At the same time, sometimes people get blinders on almost, and then everything becomes related to neuroendocrine. I see that because then I get emails and phone calls and pages saying, like, you need to see this patient for chest pain or for shortness of breath, and those are things that I cannot treat as as a surgical
Yeah.
oncologist. Number one, and number two, are not always related to neuroendocrine tumor. So the message here is you can have other problems, and not only you can, but you will have other problems because
Mm.
this disease stays with people for a long time. And it's important to advocate for yourself from a neuroendocrine perspective, but also from the perspective of, like, hey, could there be something going on with me that's not neuroendocrine related?
Mm. And it's got to be a tough journey too. I mean, I'm sure it gets confusing, but for me, folks, that is why it's so important to just listen to your body, continue to advocate for yourself, continue to ask questions. It's a marathon, right? Okay, from Trina. Trina says, does lanreotide affect creatine levels in your kidneys?
It shouldn't have an impact
Oh,
on kidney function.
did I say that right?
I think so.
Creatinine?
Creatinine, yeah.
Creatinine. Sorry, I read it quickly as creatine.
No, you're good, but no, lanreotide is not really known to have an impact on kidney function.
Okay. From Marissa, what about neuroendocrine carcinoids in the lung? Is surgery always the answer? And how often should follow up be afterwards? Is it, and would that be a CT scan?
So with a caveat that I am not a thoracic surgeon, so I don't perform lung surgery, but I do have some knowledge in lung neuroendocrine from working in that field. Again, I'll get my favorite answer. It depends. Surgery can be the answer if you have certain type of lung neuroendocrine that are better behaving and are localized. So that could happen. And the ones that have spread, so when there is metastases, it's not common that we will operate, but not impossible. There's always exceptions. And then there's some lung neuroendocrine that are more aggressive and will be treated mostly with systemic therapy, so chemotherapy first. So there's a really a wide range of lung neuroendocrine tumors, and that's why it's important to get all the information to make the right decision. And with regards to the follow up, if somebody has surgery, yes, for sure, there's a risk of recurrence, so the disease coming back, and these should be followed, and most often it will be with CT scans.
Got it. Thank you. Folks, we are just about halfway through. This is Luncheon with the Experts. We are here today with Dr. Julie Hallet. Great questions so far. Keep them coming. The 30 minutes remaining will go by quickly. Also, a question for you all at home. Adriana says, thanks for responding, but I can't travel to other countries for economic reasons. So my question for you all at home is if anyone in South America is able to chime in and maybe help Adriana, or knows any Spanish-speaking doctors who may be able to do telehealth, anything that could provide her a little bit of guidance since she's unable to travel, let us know. And thank you for being here, Adriana. Please continue to join. Next question from Tammy. Tammy says, I was wondering if there's a blood test or any other test I could take or ask my primary care physician to perform to check for paraganglioma. I previously had carcinoid tumor removed from my terminal ileum, had G2 resection and appendectomy. Fast forward 6 years, a lump appeared in my neck. It's been there for 5 years. It's hard to see my symptoms due to carcinoid syndrome. My physician who has treated carcinoid cancer is retired, so I'm starting at square one. So the primary question was, is there a blood test or another test that I could ask my PCP for paraganglioma?
So there's no one blood test to diagnose paraganglioma. If paraganglioma are functional, meaning they have produced an excess of hormones, those hormones can be tested for. Although usually people will have symptoms from that, so you would have manifestations. Mm-hmm. And not all paraganglioma will have this secretion. So some of them, the hormones will be normal. I would say that the main diagnostics would be a PET CT, so like a gallium dotatate or copper or PET CT would probably be the way to identify a paraganglioma, and it could also be completely unrelated, right?
Got it. Thanks, Tammy. Let me know if you have any questions. You okay over there, Dr. Hallet?
Yeah. Sorry. Recovering from a cold.
You need a Luncheon with the Experts mug and a sip of
Ooh,
seltzer
I love
water.
That.
If this was the Tonight Show, I'd have your own. From Cheryl. Cheryl says, I was diagnosed with neuroendocrine pancreatic cancer in 2022 and had pancreatectomy. The net metastasized to liver. The next year, I had liver resection. I'm now on lanreotide. I have non-Hodgkin lymphoma in the mesentery area. They are discussing whether to start me on rituximab. Thank you. So due to pain, will this affect my net? Is the question from Cheryl.
No, it should not. I don't think affect a neuroendocrine tumor. So we can continue with both treatments. Now, could there be some rare, interactions between the two drugs? I don't know specifically. So I'm sure the pharmacist in whichever oncology center you're going will look at that. But in theory, it should not impact the neuroendocrine.
Got it. Thank you. Thanks, Cheryl. From Jennifer, what kind of monitoring do you recommend for paragangliomas post-surgery with the primary unknown?
So everybody has to be monitored after surgery because there is a risk of recurrence, or that's the tumor coming back. Most recommendations are to use CT scans. And then if the tumor was functioning before surgery, meaning there was an excess of hormones being produced, then that should be monitored as well. And then there's different sort of schedules for the monitoring.
Got it. Question from me. We talk on here often, as I'm sure you and your colleagues do, about sequencing. And I've met surgeons. Like, my question is, are you, always surgery first if possible? Where does that fall in line for you in terms of sequencing? What things do you consider when making that decision? I know it's like a big question. It's not just this, but yeah, I'm curious your take on more appropriately your approach to it.
Yeah, there's lots to unpack there.
Sure.
But sequencing is probably one of the biggest challenges we have in neuroendocrine tumor care these days. I always tell my patients and my students that if you go to a baseball game, like baseball season is upon us, it's going to start soon in Toronto, look at those pitchers and like they've studied in every single detail the sequence of movements they have to do to get the ball in a specific location. And like I'd love for us to be able to do that, know like what's the goal here and know exactly where we can go, but reality is we have no idea. So with regards to surgery, to me, there's the main goals of surgery would be in some instances there's an opportunity for cure, but unfortunately in neuroendocrine tumors that's the minority of people that will be able to cure, and by that I mean get rid of the disease forever. Um, and then after that the goal would be to sort of slow things down, right? So I see surgery as therapy sparing, which means that it's not going to cure anything, but it can slow things down and for a while delay the need for other therapies in the future. And so that way you're able to stretch the options for therapies over a longer time. Like you said earlier, right, that it's a marathon, right? That's something I talk to people about a lot in neuroendocrine tumors. So the therapy sparing aspect of surgery is important. The second one is also for quality of life and symptom control, especially in people that have um, functioning tumors. Like the best way still to this day to bring the hormone load down is with an operation, is to remove the bulk of the tumor. So that's where I come from when I think about sequencing. Then when to use it, I think we should consider surgery early on after diagnosis. At least everybody should see a surgeon and have an assessment. And the answer may be it won't work now or it's not going to work for you. But if you don't see somebody, you will never know about that, right?
Hmm.
So that's the first thing. And then to decide whether we go right away with surgery or we wait a little bit, it depends on where the tumor is from, pancreas, rectum, colon, stomach, small intestine. And it depends on other factors like how aggressive is the tumor. So the grade, the Key67, now we can look at some mutations as well on the tumor and the PET scan avidity on the dotatate or the copper PET scans avidity, which you might have heard about. And so you put all that together. If they're sort of not very aggressive tumors and they're very functional, lots of hormones, we'll push very hard for a surgery up front and be more aggressive with it. If there's no excess hormones, so there's no functioning aspect, and it's a bit more aggressive tumors, surgery may still help, but we have to be very careful in finding the people it's going to help the most. Because the last thing we want to do is do a really big operation and end up harming people with side effects and complications and not providing any benefit, right? So there's some people where we need to select better, and the way to select and know if it's going to help is to test a tumor.
Hmm.
And the way we test a tumor is by giving other treatments first, see how the tumor does, and if the tumor stays stable or even shrinks, then surgery may help and may be a good option. If the tumor is hard to control with the medications, then surgery will not help. It's just going to provide potential for complications. So that's how I'm thinking about this. And the last thing I'd say is there's instances where you might have started your journey with neuroendocrine tumors, received lots of treatments, and you never had an opinion about surgery. It doesn't mean that we cannot do surgery if you didn't have it at the beginning. Sometimes it can help through the journey, and it's worth asking, right? Like the worst people are going to say is, I'm sorry, I can't help, but at least you've asked, and you will
Hmm.
never know if you don't ask, right?
Great point. Great point. We have a lot of really well educated folks that join the show every week in the net community in general too, I would say. But I also like to always consider someone who might have just recently got diagnosed, and I say that to set up the next question, which is very basic and fundamental. But what are some of the surgical tools or surgical methods that have evolved in recent years that really help net specialists and surgeons do their job better?
I think there's two main things for me that have improved what we can do with surgery. The first one is perioperative care. And so that's number one, anesthesiology. So the work that the anesthetists do in the operating room, they're so good that we're able to do a lot of things. Because like you don't realize while we're on the operating room table, your body is going through a whole lot.
Hmm.
And the ability for anesthesiologists to support you so that you're able to go through that trauma, it's like a trauma, right? It's worse than an accident if you think about it. So the ability of them to support you through that allows a surgeon to keep pushing. So that's the first thing. And the second thing in perioperative care is the ability to treat after surgery, to support people if there's complication, to salvage them. We have lots of new tools that are available in radiology, endoscopy, surgical monitoring that allow us to do like more aggressive but safer surgeries. So that's the first part. And the second part is I think we've understood a lot more about neuroendocrine tumors and we've been able to tailor their surgical treatments and approaches to that disease. So if you talk to a surgeon about neuroendocrine tumor, you'll get very different answers than if you talk to them about colorectal cancer or pancreas cancer that's not neuroendocrine. What we know is because it's a very very slow growing disease, we're able to aim at controlling the amount of tumor um, and not necessarily eradicate all the tumor. And we can still derive benefits from that. So that's the first part. Like we can sometimes go and when there is spread of the tumor, only remove up to 70% and still have benefits. And in order to do that, we've been able to tailor their surgeries. So if I'm operating on somebody with colorectal cancer in the liver, I will take a huge chunk of liver to remove everything and have clear margins all around. If I operate on neuroendocrine tumors, we don't need that because it's not as aggressive. So we want to spare as much liver as possible. And that's where we'll go in and like scoop one tumor at a time, even if we're leaving tumor cells behind because we're not aiming to remove everything. So it's very different techniques that over time we've been able to tailor. That's the two pieces together have allowed us to be more aggressive, hopefully bring surgery to more people and help more people with it.
Got it. Thank you. Quick question from Bernadette. Carcinoids in the lung, is that caused from smoking?
And not necessarily. There's lots of lung cancer that comes from smoking. I think you've all heard about it. It's on cigarette packs now. But neuroendocrine tumors specifically, no, there's a lot of other things that play a role. And most of those things we don't even know about these, like right now. We may know about it in the future.
Yeah, yeah, yeah. More of a comment than a question. Shane says, I just want to give kudos to all the net surgeons out there. Over the past 4 years, my mother has had over 50 tumors removed from her liver and is doing really well. That's awesome to hear. Shout out to Shane's mom, who I had the chance to meet with and talk with recently. She is just as awesome as Shane is. Maybe part of the reason why Shane is so awesome. Thanks, Shane. Appreciate you. Next question from Michael says, "What is the risk of developing other types of cancer after having had an ileum tumor with liver metastasis and lymph nodes removed?"
So that's interesting. The question of having second cancer after an neuroendocrine tumor is discussed quite often. Um, One of the reasons being that, again, because people like you with neuroendocrine tumors can go on to live for years after treatment with a neuroendocrine tumor, you have plenty of time to develop another cancer. And some of it is just cancer that anybody else can develop, and some of it may be cancers related to the like linked to the neuroendocrine tumor for reasons that we may not fully understand yet. We did a study a few years ago with one of our clinical fellow in Toronto. We looked at the SEER database in the United States. People may have heard about SEER. It's essentially a registry of epidemiology in that captures most of the population of the United States and looks at cancer diagnoses. And so there are a few cancers that can occur after neuroendocrine tumors more often than somebody without a neuroendocrine tumors. Um, I'm going to be really honest, Michael, on top of my head right now, I don't remember all of them. But again, I can use my X platform and put some of that information and some of those figures up there so that you can look it up. In general, I'd say right now we know that there is a higher risk of certain cancers. We just don't know what it means and what we should be doing with it. So we're still working on that. Right now, I'm looking at data in Canada to see if it's the same as in the United States. And then eventually, the goal would be to come up with an expert consensus to say, do we need to screen differently after somebody had a neuroendocrine tumor from some specific cancers, for example?
Got it. Thank you. Thanks, Michael. And by the way, folks, I just reminded myself of something when I was talking about Shane and having a chat with his mother. And this goes back to what the announcement I gave at the beginning about CCF's role and what they're doing currently pertaining to the Facebook post you also saw about them stepping back to self-assess. We are still doing programs with them, and we are constantly looking for patient stories. Some of you all know the documentaries that I produce for the foundation, the different patient stories of how they emotionally and psychologically navigate this disease. I'm always looking for people to help tell their story. So if you know any patients, this is for you too, Dr. LA. Any stories that are interesting or like a kind of a, I don't want to say a weird. All the diagnosis stories are unique, and sometimes they're more. What's the word I could use? I don't know, compelling. I mean, just interesting or wild scenarios that have happened. I've heard it all, folks. And those can be really interesting, but also the people, like people that are going through it that are um, you know, everybody is special. Everybody has a story. I fully believe in that. There are some people that are more active or just have an interesting story. There's no rules. I mean, because I like to talk to everybody. So if you have anybody in mind that has what you think could be an interesting net story, and the real goal is that would be helpful for other folks to hear, that's what I find is so exciting is like if I see Tom's story, I'm making that up, and it's similar to mine, I relate to that, and it gives me hope, it gives me guidance sometimes, another perspective of looking at it. So that's what we're always looking to. It's always about the heart and emotion. So just consider that. You can always message me. My name is Rain Bennett. I'm easy to find on the internet, and of course you can message the foundation too. Okay, we've got just more than 10 minutes. Let's try to get to as many as we can. The next one comes in from Kanina. Kanina, hello. I had a lobectomy of the upper right lobe, which had an atypical carcinoma, Ki 6740%, stage 1B. But in my second follow-up, now I have a mass growing fast in the pleura and back. What should I do? PET scan, or could it just be fibrosis growing? It doubled in size in 3 months.
That's hard to know. It really depends on what the images look like and a lot of other information. I'd say that fibrosis in general doesn't grow. It stays the same, or it can get smaller over time if it's related to, changes or scar tissue after surgery. So definitely, this would need to be investigated. Maybe check in with your oncologist or your lung surgeon to look at that because if it is truly a carcinoma, those have a tendency of coming back.
Got it. Thanks, Kanina. I think that's the first time I've seen your name here. So if you're new to the show, hello, welcome. Does reducing tumor bulk in the body allow treatments like PRRT or other systemic treatments to work better?
Yeah, look at Shane coming in with all the good questions.
Always.
Yes, so the answer is yes, I think so. Can I demonstrate that without reasonable doubt? Probably not with the data we currently have, but I'll tell you where I'm coming from with this. So, first off, with somatostatin analogs like octreotide LAR or lanreotide, we know from the two main studies that were done that in patients that had less tumor in their liver, there was a better response. So the time to progression was longer in those people. That's from what we call subgroup analysis, meaning we took all the patients in the study and we look at a group of people that had less tumor in their liver and they tend to do better. So the way I'm thinking about it as a very simple surgeon is if I can reduce the amount of tumor in the liver below those rates, then that might allow for the somatostatin analogs like lanreotide and octreotide LAR to work for longer. Sort of makes sense to me, right? There's less tumor to fight, they can work for longer, and there's some data that would support that. That's the first part. The other part is with regards to PRRT. Um, we think that if we're able to get some of the tumor out before starting PRRT, it can work better. So there's actually data from a study in Italy where they looked at patients with pancreas neuroendocrine tumor that had metastases to their liver and that were not amenable to surgery for the liver. And what they did is some of the patients had their pancreas tumor removed before surgery, before PRRT, and they noticed that the ones that had their primary tumor removed before PRRT had a better response to PRRT and potentially had a better survival. Now, I have to give the caveat here that There's a reason why some patients were selected for surgery and others were not, and that might explain the difference that we see. But there's a signal there that there could be a difference. And again, it makes sense, right? It seems like common sense. Less tumor, it can work better. The question is like, is the squeeze worth the juice, right? Like, is putting
Mm.
somebody through a big surgery worth the benefit you're getting on the PRT response? At this time, really don't know. But some much smarter people in Europe have put together a clinical trial for this. I'm not sure what the status is now, but I know they've been working on it.
Got it. Thank you. And yes, thanks to NCF for putting my Twitter contact up there. Bernadette said she had an interesting story. And Robin, you can, my website's Rain Bennett. You can message me and find me on Facebook, et cetera, et cetera. We've have several more projects coming up. That's what I meant about referring back to the comment I made about CCF's role. So we'll still be doing many programs and projects for the rest of this year. From Stephanie, what are your thoughts, Dr. Hallet, on using Y90 for targeting large tumors in the liver? I've noticed there are varying opinions on this.
Yeah, another big controversy. You're all hitting the tough questions.
They always do.
Yeah, very well informed group of people attending. It's fantastic to see. I love that people have knowledge and understanding of this tumor to be able to ask those questions. Again, speaks to the community you were talking about earlier.
For sure.
So with regards to the question, I'm not avoiding it. There's so when there's a very large tumor in the liver, the first thing for me would be like, could this be approached with surgery? Because sometimes there's patterns where you have one large tumor and a bunch of smaller ones, and the larger ones are more difficult to treat with embolization. People get pain, they get necrosis or like liquefaction of the tumor in the center. That can be a problem. So there's instances where we're able to actually remove the very large one and then leave the little ones to be treated with liver embolization. Now, with regards to if surgery cannot help, whether Y90 or another type of embolization, if there's a very large tumor, Y90 may be really good. The difference with Y90 is that it goes into the very little blood vessels, what we call a microembolization, the very little ones, and so it can help because you have to treat a lot of liver when you have a large tumor. So if you use some that block the larger blood vessel, you're sort of treating or exposing more liver to treatment than if you use ones that are more targeted and can go to little blood vessels, if that makes sense. Um, the one thing to be careful with Y90 is, from my perspective, it should be used only in very specific settings. So, like you're saying, a large tumor that is not amenable to surgery, for example, and you want to avoid treating a huge chunk of liver for it. If people have gone through multiple rounds of embolization in the past, and over time, what happens is the bile ducts can start to suffer from traditional embolization. So after a few rounds, we want to go to Y90 so that again you're targeting more smaller blood vessels and you can prolong the lifetime of embolization for treatments. And then those are the main ones where you want to use Y90 from my perspective. I'm pretty hesitant using Y90 as the first embolization modality because we know that it can create fibrosis in the liver over the long term because it is a form of radiation, right? And the problem with neuroendocrine tumors is, again, people live for a long time, so that fibrosis may become a problem. It's not a problem in diseases where we use Y90 more often. We have more experience, like liver cancer, like hepatocellular carcinoma, for example, because those people don't live as long, so may not run into problems from the fibrosis. That's the first thing. And the second thing is some people will have PRRT later down the road, and both Y90 and PRRT are a form of radiation. We think that it can be safe to do one and the other after, but not in everybody. It depends on how long there is between the two treatments, how much radiation is given, and there's still lots of unknown there. So that's why for me, Y90 is in very specific circumstances because there's still opportunities to harm people either by side effects in the long term or by precluding other therapies afterwards. So I'm pretty careful with it.
Got it. Really quickly, Cheryl says, could we get the name of the database that you mentioned that lists those with multiple cancers?
Sorry, can you just repeat that?
Yes. Could we get the name of the database that Dr. Hallet mentioned that lists those with multiple cancers?
Yeah, it's the SEER database, SEER. I cannot remember exactly what it stands for, but it should be fairly easy to find. And again, I'll try to put those results on my X/Twitter feed.
Yeah, I think, and we'll try to get the link in there before we close out the show, Cheryl. It's I see it right now. It's I think seer.cancer.gov.
Yeah.
But we'll try to get someone to type that in for you so you can just click the link. Next question from Sasheen. Hey Sasheen, where you been all day? Hi, if a net spreads to a postmenopausal ovary, are there any special considerations in treatment? Known small SI primary, already stage 4 with liver mets, grade 1, surgery already in the planning for resection and debulking.
Yeah, so there's a role for removing the ovary as part of debulking and cancer control. So again, that depends on where other treatments are going. But if debulking is in the cards, then that's totally feasible. Yeah, I've done it several times.
Got it. As always, before we leave, a question about histotripsy, at least one. Donna says, thoughts on histotripsy versus Y90?
Yeah, so those are very different types of procedures. So Y90 has some caveats, like I mentioned, but it's a quite proven procedure. We have lots of experience with it. People know how it works, know how to follow it up, know what the results to expect. Histotripsy is a very new type of procedure, was just approved by the FDA this year. And I think we have to be careful because we don't know much about it. The only data that it was approved on is based on like we were able to ablate the tumor and create pretty images in the first few months right after, but we don't have long-term outcomes, meaning we don't know how much tumor control we can get in neuroendocrine. We don't know what the survival and recurrence rates can be in the future. So from my perspective, histotripsy could be used to control one particular tumor. Um, if other therapies like radiofrequency ablation, microwave ablation, or surgery are not feasible, like it's an ablative technique. So if there is nothing else feasible for that, then there may be a role for histotripsy. To be quite honest, it's pretty unusual that all the other ones cannot be used. That's the first thing. And the second thing, I'd be careful also. Lots of people out there are selling histotripsy for something called the abscopal effect. The abscopal effect is people think that if we treat one or two lesions, the other lesions in the liver will also respond.
Hmm.
There's some like it's immune mediated process, and there's evidence about it in mice. But I would say that humans are not mice, and so we don't know how tumors are really going to react. We have no proof this abscopal effect works in real life. So I wouldn't go for histotripsy if it is because of the abscopal effect that we want to use it. We need much more information about it to know if it's a real thing.
That's a fair point. Thank you. And thanks for your question. From Christina, can you tell me the difference between alpha and beta PRRT?
Yeah, they're essentially two different compounds. They work through different mechanism. Now, I'm not a nuclear medicine doc or a radiation oncologist, so I don't know all the exact details. Alpha is a new type of PRT that is being studied right now. There's a few ongoing trials, and so we'll get information about it in the next few years, I hope. In initial studies to test its feasibility and safety, it seems to be able to generate a very drastic response. My understanding is it may be a little bit more difficult to manage and may have a little bit more toxicity, but that's something that we'll see in the future trials. But definitely lots of potential if it works well.
Got it. And final question, I asked you earlier about some of the surgical tools and things that have evolved over the past few years. Flip that question. Are there things, not necessarily only surgical tools, are there developments that you would love to see in the next couple to few years that would really, help you perform your job better? Whether it's treatment, whether it's diagnostics, anything.
Yeah, so two things I really would like to see is number one, having good systemic treatment, so medication that we can give around the time of surgery.
Mm,
Whether we can give it before surgery to shrink tumors
right.
so that more patients are amenable to surgery, or to shrink tumors so that we can do less extensive surgery and have an easier recovery for people. That would be great. And in particular, in small intestine neuroendocrine. We talk a lot about pancreas in this combination therapy and systemic therapy. We have very little for small intestine. And there's so many people that have those gigantic mass in the mesentery and circling blood vessel that are super symptomatic. And right now, I am not able to operate on everybody because some are too advanced, and we have nothing that can shrink it. So if we could have drugs in the pipeline that will help with small bowel neuroendocrine, not only with pancreas, like that would be absolutely amazing and a game changer. Um, if you could also have drugs we can give after surgery to prevent recurrence and reduce the risk of recurrence and improve survival after surgery, that also would be amazing. And then finally, some people are working on something called a like a gamma probe.
Mm-hmm.
It's a probe that will detect something similar as what we give for PET scans. So, like, you give a compound similar as what people get for a dotatate or a copper PET scan, and we give that before surgery. And with a little probe in the operating room, we're able to detect the signal, like where, because sometimes some lymph nodes are small, like we're not able to find them. It's like a needle in a haystack. But with that probe, we might be able to find a needle and then complete more, complete surgeries. So those are the things I'd love to see in the next years.
Awesome. Love it. Well, folks, that is our show for today. Michael says, thank you, Dr. Hallet. We appreciate you sharing your knowledge and insights with us. Blessings. Couldn't agree more. Appreciate you being here very, very much.
Thanks, everyone. Thanks for joining and being so engaged. And again, like, the amount of knowledge and understanding of this disease and level of informed questions everybody is asking is like, it's truly amazing. Every time I come to these meetings and programs, I get renewed energy to continue to work. So thanks to all of you.
Awesome. And thanks to you, you all at home for joining us. As always, we hope this program helped answer some of your questions. I want to reiterate one more time that Luncheon with the Experts is going nowhere. We will be back in 2 weeks with Dr. James Howell, and we are booked all the way through the summer at this point, and NCF plans to book the rest of the year. And after that, hopefully we'll come back, but it will help if you all let them know how much you love the show and the host and all the great guests that we have. But sincerely appreciate you all being here. It's a pleasure, something I'm super grateful to be a part of, and I'm glad to have you here every week. My name is Rain Bennett. I am your host. Thank you for watching, and please join us next time in 2 weeks on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye now.